have a great, entrance and exit area and a one way, so you can actually feed these patients in and have an area where they can, a lot of times, sit and wait. So a lot of times we'll have, I know when I set up triage areas for these, I would typically just have chairs outside of our immediate and delayed treatment areas, and we would just have chairs lined up like it, you're at a briefing or something, and they would just sit down in those chairs and kind of wait. Or you may have, if you have enough personnel, you might have just one person out there providing minor treatment to them. So just some bandages so they can wrap wounds, and really somebody there to assure the patients and help take the load off of the immediate and delayed treatment category or treatment personnel. And then, like I said, initially you're able to treat, so a lot of times we'll put them in the expectant category. So this might be obviously no vital signs. It's going to be unlikely salvageable. Any sort of, like I said, GSW to the heads with a coma, brain matter exposed, any if they had open pelvic injuries that where there was treatment delayed and they've already lost too much blood for you to be able to save them. These are patients that commonly might go into that category. And even sometimes high spinal cord injuries, you have to think about your resources and what we're going to be able to salvage in these patients. So these can sometimes overwhelm you, but this is one, like I said initially, don't abandon them. You want to have somebody. Oh, sorry, can you guys hear me? I don't know what happened there, why it went muted. I didn't touch anything. All right. Hopefully y'all heard me talking or not. I don't know when it went muted a second ago. But just to reiterate, these are patients, obviously non-salvageable injuries. So the GSWs or brain matter exposed, or any head injuries or brain matter exposed, like severe shock, that would require too many resources to save those patients. So, you also have to look at your blood supply, how much blood you have on hand before you start treating the expectant casualties or trying to salvage them. And then, like I said, don't abandon them. You want to have somebody back there monitoring them. Sometimes it may just be your chaplain, maybe one medic. It may even be somebody non-medical or somebody who isn't on your medical team but has maybe a little bit of medicine experience in the past. You may have people who were prior EMTs that work in S1 or somewhere else, or infantrymen, that you can have monitoring these expectant casualties, because you'd be surprised some of them do survive, even if it looks non-salvageable. I've seen patients with severe head injuries or brain matter exposed that ended up ended up surviving and doing relatively fine, but they were initially triaged as a expectant casualty. So this is something to always consider, having somebody back there monitoring them in case you have signs of life return. All right. So obviously when you triage, you want to frequently reassess these patients. It's a fluid process. So somebody who was, you may, depending on how quickly you can get a tourniquet on that patient, they may go from immediate to delayed. So since it's, a fluid process, you want to continually reassess these patients. Anytime you move a casualty, you want to look at if they had a tourniquet on, you want to reassess that tourniquet. Even some of the best placed tourniquets after moving casualties from, if they weren't on a litter, they were on the ground, to a litter, sometimes those tourniquets can loosen, so you always want to reassess it, assessing distal pulses, obviously going through your primary survey again and reassessing your ABCs. And then we have our documentation. So, for the military, we have our field documentation on our TC3 card, which is pretty simple and straightforward. It doesn't typically require a medical person to fill it out if you have somebody there to help as well. And this is why this is why we practice mass cal drills, so that we can have personnel there to take care of everything. Like, it's important if it's in the military setting that you're involving like your S1, because they know personnel, they know numbers. So it's important to have them there so that they're actually monitoring who's coming in and out. That's a lot of times what we utilized was our S1 as tracking function for all of those casualties that came in. So they're typically with that triage officer, obviously not getting in the way of any sort of medical treatment or evaluation, but they're there so that they can monitor and track which patients are coming in and out. That's an important function. You don't want to have a mass cal and, you know, it's 15 or 20 casualties come in, but you have no idea who came in, what casualties, and where they went. So it's important that you involve all of these personnel before a mass cal and practice this. That's why the hospitals practice it frequently, sometimes monthly or quarterly, depending on where you're at, so that we have all of our personnel respond in an appropriate manner. I know when we were downrange, we would do it monthly on whatever outpost or FOB we were at, and we would have monthly mass cal drills and simulated patients just so we could run through the motions and everybody knew where they needed to be, whether it was S1 showing up at the triage area so that they can track these patients, and then any sort of other medics we had that were located throughout the outpost, if they were line medics or what. All right, let's move on to a question here. These seem to be kind of tricky sometimes when we're just reading it in a question and deciding what category they are. So what are we thinking on this one? I'll give you a second to read it. What do we think? Y'all can chime in or whatever. Everybody, what are we saying? 4? Got some more saying, yeah, 4. Urgent surgical, okay. 4. All right. Well, yeah. So the answer on this one's going to be delayed. But yeah, I see commonly most people when they read this think minimal. A few will say immediate, but this patient is going to be delayed for this. So, I mean, what you're looking at right here, so you have multiple small penetrating fragmentation injuries through, basically almost over the whole body. So you got some on the extremity or the lower extremity, the arm, upper extremity, and you have the thorax and abdomen. However, their GCS is 15. Right now, it looks stable. Would everybody agree that we call that patient stable? Hopefully we can agree on that. I mean, they're not hypotensive, they're not tachycardic, they're not tachypnic, O2 sat's good. However, they have multiple penetrating fragmentation injuries, so we don't know how deep those are. So they're likely going to require further evaluation and possibly surgery, but right now that patient is stable, which is why we're going to call this delayed. So just because of those, then the reason it's not minimal, you have those fragmentation injuries. How do we know it hasn't penetrated the abdomen or the thorax? We're based on their vital signs, we're going to say they're stable. So it likely hasn't, but we'd have to explore those a little bit more. So they might require surgery or a little bit more definitive care later on. But right now, we can categorize them as delayed. They don't need immediate attention right now, but they may need it later as we're reassessing that, because one of those penetrating fragments may have penetrated, the peritoneum, or it may have penetrated the thorax. But right now we don't have any objective signs of that, like in their vital signs. So that's why this would be a delayed patient. So everybody kind of tracking that and understand, hopefully. What questions do we have on this? Anybody? And if you do, I mean, you can chime in here or type it in there or just talk. Yeah, so good. And yeah, so I kind of see it's all over the place, which is typically what we see. I think most people tend to say this is minimal, but this is going to be a delayed casualty. All right, so medevac. Here's obviously you don't need to know the 9-line medevac. We're not going to test you on the 9 lines, but that's what we use, obviously, in the military. Um, However, we do like to use a MIST report, and EMS around here also uses the MIST report as the standard. So we're looking like at our mechanism of injury, whether it's like a strained MVC driver, what injuries do they have? So like they might have a right lower extremity fracture. How are their vital signs? So their GCS is 15, their vital signs are stable. Since that's a fracture, a lot of times we like EMS report, they have distal pulses, so their DP, PT pulse is intact. If we're talking about like a right lower extremity fracture, we have an IV placed, we've given 50 micrograms of fentanyl and placed in a splint is typically how your MIST report is going to go. All right, so we'll talk about hospital phase and preparation. Oh, hold on, all right, so talk about the hospital phase preparation. So this is obviously, like I said, you have to have some advanced planning. This is why we rehearse and we practice these. It's why we establish MassCal protocols. But for the hospital phase, you obviously want to have that smooth handover process, typically directed to the trauma team leader, kind of like we practiced yesterday in those trauma scenarios. So you're going to have your handoff from EMS. And so, like I said yesterday, based on that handoff, so if the patient's stable, obviously you can take some time transferring that patient over into the bed and from EMS. But if they're not, or they don't have an airway, or they're unstable, then we may have to stabilize them first before we get a good EMS report and before we do a handoff from EMS. And then obviously you want to make sure your trauma team is wearing their personal protective equipment. That's something we didn't focus on yesterday because we don't have the equipment, but typically we'll have a face mask, eye pro, and then some sort of gown on when we're treating these patients. All right, so let's talk about our primary survey, which is what we did yesterday during our lab, and hopefully you all got kind of a basic idea of how the primary survey works. So this was established by the American College of Surgeons, and we followed the Advanced Trauma Life Support guidelines for the primary survey, which is, like we said yesterday, it's they still publish these guidelines, and they go by the ABCDE mnemonic. So airway, breathing, circulation, blood exposure. They have added stop any life-threatening bleeding first for the ATLS algorithm, but it's still not. But they still teach the ABCDE. And it is important to say, I know for I can't speak for the other services, so sorry, but the Army requires in a battalion PA to be ATLS certified. So on your MTO, it is coded as an ATLS slot. So this is something you want to discuss. Hopefully you can get this completed in phase 2, and they can send you to this course. It's usually a couple days. But if not, this is something you have to do once you get to your duty station and ask them, hey, how do I get ATLS certified? It's typically a 3-year certification, and it's ran by, like I said, the American College of Surgeons. So typically it'll be run by surgeons and typically emergency medicine doctors. And it's a good course that just teaches you some of the basics on your primary and secondary survey and some life-threatening injuries that you're going to see out there. All right, so here's our primary survey, similar to what we did yesterday. So you're going to have your exsanguination, stop any external bleeding, so your X, and then your ABCDE, so airway. Are they, do they need an airway or not? Are they talking to you? What was the mechanism of injury? Do I need to place a C collar on them? Are they breathing? Do I got symmetric chest wall motion? Are there any penetrating injuries, chest wall tenderness? What's the respiratory rate? And then circulation, do I have pulses in all 4 extremities? What's my blood pressure if we have, if we're able to get a blood pressure cuff on and at that point? And then our brief neuro exam, what's their GCS? How are their pupils looking? Are the pupils unequal? Do I have a good pupillary response? And then we have to expose them, so we want to undress them to find all the injuries, but we also want to prevent hypothermia in these patients. So we want to make sure we cover them after we strip them naked, and we just don't leave them there like that. This is why a lot of times in your trauma rooms, there'll be like 90-some degrees in there, just for those situations when the patient's stripped. And if there is some sort of procedure or treatment that requires, prolonged exposure, that is still warm in that treatment area as well. And then we have in the notes there, obviously our MARCH is a great acronym that we use in the field during tactical combat casualty care, which is similar to exactly what we're talking about for our XABCDE. So it's massive hemorrhage, airway control, respiratory support, circulation, hypothermia, and head injury. And that's just looking at the most common preventable causes of death on the battlefield. So we use that MARCH algorithm, which is a great algorithm as well. All right, so here's, a little bit easier primary survey here. So obviously looking at our two most rapid causes of death. So massive bleeding, did we stop the bleeding? And are they breathing? Or do they have an airway? So obviously, like I said yesterday, when they bring that patient in, typically we ask them, hey, what's your name? And then if they can talk to you, great, they have an airway. If not, then we need to maybe move a little bit faster and take their airway. And then we need to get them naked, looking for any hemorrhage, roll them. Do I have anything on the posterior thorax? And then typically we get a chest x-ray. When we roll them, we throw a plate under them, and we look at, obviously looking for pneumothorax, hemothorax, looking at the mediastinum, and then fast exam is a great adjunct we can use during our primary survey to look for any sort of signs of internal hemorrhage that we're not able to visibly see. And yesterday, some of the groups, we kind of had some confusion because we look at this in a sequential manner, A, B, C, D, E, F, G, but most of the, if you have a trauma team or more than one person, this is all happening at the same time. So I noticed yesterday sometimes we would continue with our primary survey and overlook some of the interventions that we did or didn't do. So when we find anything on the primary survey in our A, B, C, D, E, we need to address those before we move on throughout the rest of our primary survey. That's why we do it in this sequential manner. So if you notice that they have, decreased breath sounds on one of the sides, we need to make sure that we're providing an intervention for that, whether that's something temporizing like a needle thoracostomy, or whether that's something more definitive like a tube thoracostomy. So we don't want to move on to the next step in that process until we've addressed that life-threatening injury and stabilized that patient. So if we're on our circulation and we notice that, their blood pressure is 88 over, 45, we need to make sure that we're, in a trauma patient, we need to make sure we're evaluating for hemorrhagic shock and exsanguination. So we need to make sure we get blood on board on that patient before we move on to the next step in our process. A lot of times when this patient comes in, we will get 2 large bore IVs, so we will draw labs on that patient. Typically that's just a 20 cc syringe. We just pull 20 cc's and then we take that and run all of our blood tests. And that usually does include like a VBG as well, so we can get something immediate, usually like 2 minutes. We can run that on the iStat, so a lot of times you will have that back initially, but sometimes the initial hemoglobin will be misleading, so we don't technically like to treat numbers, but we do want to consider that. All right, here's another wonderful, complicated algorithm, but really it just talks about it basically is just a nice graphical depiction of everything we've talked about so far. So we have our initial field triage, our communication with medical control, followed by our initial resuscitation, and our AVCs, primary survey, and then any adjuncts we did to the primary survey, which is like our FAST exam. And then we need to evaluate their response to resuscitation, which is probably one of the most important. So let's say we identify that this patient was in shock from exsanguination, and we've initiated blood. We need to then reassess and evaluate. So they may not be completely stable, but if they were initially hypotensive, and now we've got their blood pressure, back to 99 or 100 over whatever 60, 50, we're seeing a response to that fluid resuscitation. So that's an extremely important part of well, extremely important thing we're doing in this initial resuscitation. So if we've demonstrated that they're moving towards stability, we can move on throughout our exam. Now, if they aren't responding to that initial fluid resuscitation or blood, that's a very important indicator that they need to get to surgery immediately. And then one of our adjuncts that we can use is obviously the FAST exam is our most rapid and reliable method of identifying any inter-abdominal free blood. So it does have a pretty high, specificity and a decent sensitivity. So, but sometimes this can be difficult. We may not, initially have a positive FAST exam. You can lose a lot of blood into the belly before you get a positive FAST. And different studies have demonstrated different, amounts, but you just have to think of how much blood you can lose in your pelvis, which is like, some say up to 3 liters, and that may not be identifiable initially on the FAST exam, but after a couple liters of blood loss, you're going to see that patient's vital signs are going to be significantly changed, and they're going to be in shock, and you may not have a positive FAST. So we're treating the patient, not our, imaging exam findings. So it's always something to consider. They can lose a lot of blood in the belly, and we don't have a positive FAST. So if they're not responding to that fluid resuscitation, even though they have a negative FAST, we still need to think about they're bleeding somewhere, and we need to get this patient to surgery. And then more of our initial approach to different kinds of shock and what we're doing to treat them, which, obviously, if they're hypovolemic shock, which most commonly they are from a trauma patient. So any hypertension in a trauma patient, we need to presume is secondary to hypovolemia, even if they have a head injury. So we don't want to chalk that up to their head injury being the cause of that hypotension. If we have our polytrauma patient and they have other signs of injury, like they could be, exsanguinating in the belly, we need to assume that hypotension is from, or presume that it's from hypovolemia and not some other head injury or neurogenic shock. So in a trauma patient, those are going to be, this is going to be presumed hypotension from hypovolemia, and we need to treat accordingly with blood or the appropriate fluids for them. And then we need to evaluate for those other causes in these patients, on whether that, could be cardiogenic shock. And that's why we're throwing that ultrasound probe on there. Do they have, any pericardial tamponade? Do we suspect any blunt cardiac injury? Is this tension in the thorax? And we need to treat accordingly. All right, but the trauma team roles. This obviously usually is led by your most experienced trauma surgeon. Different facilities are going to have different policies. Like at a level 1 trauma center, there are guidelines, and what it really means for like your level 1 trauma, level 2, level 3 is what sort of ancillary or secondary support you have for your specialties. So typically a level 1 is going to have neurosurgery 24 hours a day, 7 days a week. They're going to have all of your other specialties, your orthopedics, your anesthesia, and any other specialty provider that's going to be required to treat these patients is going to make it a level 1. So in a level 1, you're typically going to have a trauma surgeon leading your trauma team. So they typically, like we did yesterday, they stand an area, or we had the team leader. When I was there, I tried to make sure the team leader wasn't actually performing treatments. They're basically the puppet master. They're guiding all of these people or all of these other providers or nurses, and they're taking in that entire exam. So you'll typically have, obviously your EMS is going to be delivering the patient, and you will give you'll take a report from them as long as the patient's demonstrated some stability. And then you have your airway person, who typically covers clavicles up. So they're obviously neck up exam on these, making sure the airway is intact and checking for any HENT abnormalities. And then you have your clavicles down, and if you have, like we had yesterday, typically 6 people in each group, so you'll have team leader, you'll have your airway or clavicles up person, and then you'll have right side clavicles down, left side clavicles down, a scribe, circulator or drug pusher, and then whatever other ancillary staff like your radiology techs usually are typically there. And then you may have, other medical techs who are getting IVs for you, which is, the ideal situation. You typically don't want your, doctors or PAs doing the IVs. You want them evaluating that patient for any significant injuries that require treatment, like a tube thoracostomy. But like we have in the notes, so yeah, the reason we established these trauma teams is because there have been studies that demonstrated if you have a team leader and an actual team that is assigned prior to arrival, and they've practiced this and they're well rehearsed, that you can cut time to resuscitation by 50%. That's why it's important. And I know I told some of you guys yesterday when we were doing these scenarios, this is why it's important. You guys are going to actually have to practice these when you're in your aid stations, because a lot of your medics won't have this experience. So that's why a little over a year from now, you guys are going to be the ones who are running this, and it's important to practice it. I know you're going to be stuck doing sick call and whatever else, and profiles and seeing patients in clinic, but it's important you're actually linking up with your medics hopefully once a week, and you guys are running through scenarios like this so you have a well-oiled machine, because practice makes perfect. All right, so in the ideal world, how it works, the patient arrives, EMS comes in, you're gonna, if depending on, it's facility dependent. So like when I was at Darnell, we would get the EMS report as long as they were stable before we moved the patient from the EMS stretcher into our bed. But that was a level 3 trauma center, so usually the patients are a little bit more stable unless it was like a CPR in progress. At most level 1s, we typically move them to the bed first, demonstrate stability, then take an EMS report is typically how we perform this. So EMS arrives, like I said, the first thing you're asking when they come in the door, hey, what's your name? Okay, great, are they talking to me? They obviously have an airway. If not, then we need to move them quickly and take that airway or secure that airway. And then once we move them over into the bed, if they're stable, we've got the EMS report. If not, we're doing our primary survey immediately. And it's all happening at the same time. After the primary survey, we obviously, if we have treated all of the injuries that we've identified, if we identify any life-threatening injuries, we treat them, and then we're moving into our secondary survey. And then, we typically get our report, like I said, whenever we demonstrate that they're stable enough for them to give us a report. And then we do our secondary exams. We get our imaging ordered. A lot of times, if they're stable, they're going to go to the CT scanner. Typically, you'll hear a lot of times, we say PAN scan. What a PAN scan means is typically is a CT, non-con head CT, non-con C-spine, and then contrast chest, abdomen, and pelvis is typically what a PAN scan means when we're talking about it in the trauma room. One of the important things we need to think about when these patients arrive, and I mentioned it a little bit yesterday, if they come in and they're intubated, we need to verify that tube has gone through the cords. So that's not like with the chest X-ray or end-tidal CO2. We need to actually take our laryngoscope. Typically, it's video laryngoscopy in most hospitals, and we need to visualize that tube is going through the cords. We also need to listen to the lungs to make sure it's not like a right mainstem intubation, it's not malpositioned. So this is something we need to do. That's one of the first things we do if they're intubated by EMS, is verify that it's in the correct place. All right, let's take a 10-minute break. Everybody be back at 9, okay? And I'll hang around for anybody who has questions right now. Extremity bleeding, and we suspect it's arterial. We can place a tourniquet on that patient. We also, can apply direct pressure, obviously for any sort of non-extremity bleeding. Then we need to think about our significant bleeding from those non-compressible areas where we can't put tourniquet on. So, you know, in our junctional areas or anywhere else, we have our hemostatic bandages. So like the most common one on there, and I think the one we have in our, you know, in all of our like first aid kits that we carry with us, and all of the soldiers should have a combat gauze, which is, you know, basically gauze with the hemostatic agent impregnated into it, which can also help with hemorrhage control. So obviously it's always something to consider when we're using our combat gauze or any of our hemostatic agents. It does, you do have to apply it directly to the arterial bleeding. So sometimes that bleeding can be significant. Typically, like I said, in the pelvis area, you may not be able to directly see the bleeding. So in order for it to work appropriately, you do have to visualize where the bleeding is and apply that dressing directly to it. So it's not just something we, you know, open the package and ram the whole thing in there. We need to apply it appropriately. And we will demonstrate how that works to you when we do our ATM lab on the CAM model. So you'll be able to use it, you know, see how it actually stops hemorrhage or doesn't, depending on if you use it appropriately or not. So, which will be based on whether you need to. Yep, somebody's micing.
Something what? Just for you.
Sorry, I'm just listening to all the action here. All right, we'll keep going. So yeah, we'll demonstrate how to use these dressings appropriately when we're in our ATM lab here on April 15th. All right, so here's a patient. I'll give you guys a second to read this, and then we'll discuss, you know, what the answer is. All right, so what do we think here? Yeah, by direct pressure to the wound. Good. Yeah, so this is, you know, obviously we got a 66-year-old, you know, he's got some sort of pruning injury to the right thigh, 7 centimeters. He is on a blood thinner, so that, you know, that's something to always consider. He's taking warfarin for AFib, so he may have an increased bleeding risk, but you have a 7 centimeter simple superficial lac, dark blood oozing, so typically, you know, by the way the question's making it sound, obviously like some sort of venous bleeding from the defect, you can probably stop this hemorrhage with direct pressure. All right, so moving on to airway. So like I talked about initially, we need to, you know, if the patient's talking to you, obviously they should have an airway if they're talking. But where it gets complicated is obviously when they don't. Well, if they're not talking, we need to then do a little bit better assessment. So let's say they're, you know, maybe they have a head injury, maybe they have some sort of other reason other than their airway of why they're not talking. So then we need to assess that. So we need to open their airway. Do we, like, do I see any signs of any foreign bodies in the mouth or the oral cavity? Do I have any facial fractures? Do I see any like tracheal or laryngeal injuries, or do I just maybe need to open, you know, do some sort of maneuver, whether that's, you know, a jaw thrust and open the airway, or do I need to suction during secretions and then maybe that stabilizes their airway? So we need to do, you know, perform these measures first. We don't always just jump up, throw a tube in them. We also have our other, you know, airway interventions, which we'll talk about next. But we also, you know, during this time, we do need to, you know, assess, especially blunt trauma. Do I have a cervical spine injury? We need to think about that as well. If they don't have a seat collar on by this point, we should probably throw one on there. So here are some of, some of our more less invasive airways. So we have our nasopharyngeal airway, which is just our nasal trumpet, measure from the nair to the earlobe, insert it, into the nair. Typically, we say the bevel towards the septum, but they're only designed to go on one side, so you may have to adjust accordingly, or sometimes you can cut it if you're placing it into the opposite nair than where it's supposed to go. And then we typically like to lubricate it first. We can insert it into an awake and alert patient that has a gag reflex. The only contraindications are really any sort of like basilar skull fracture, facial trauma that would preclude that. As you can see in one picture there, it looks like an NBA going in the brain. So obviously, like I said, any facial trauma, you want to avoid that. Then we have our oropharyngeal airway, which is going to be, inserted in the mouth, typically measured from the corner of the mouth to the ramus. Then we want to insert the tip up and then rotate it 180 degrees once it's in the posterior oropharynx. Now, this obviously can't be placed in somebody with a gag reflex, or you're not going to enjoy what happens next if they do have a gag reflex. So this is going to be like your obtunded patient without a gag reflex, like possibly comatose, anything like that. And then we have some other interventions here. So we have our supraglottic airways, which are very common. I think the most common now is going to be our i-gel airway, which is just a supraglottic airway with some gel inside of the cuff, so you don't have to inflate the cuff. And they work really well. Typically, it seats at the epiglottis and prevents gastric inflation. These are obviously contraindicated with the gag reflex as well. And then moving up to our more definitive airways, which is going to be our endotracheal intubation, so typically with laryngoscopy, or some sort of video laryngoscopy, but this one's placed in the trachea. You want to visualize the tube going through the vocal cord, so that's why the video laryngoscopy is nice. So the trauma team leader and everybody in the room can see on the video screen or the monitor that airway is actually, you can actually visualize the vocal cords, and you can watch the airway pass through the vocal cords and the balloon. So, video laryngoscopy is a preferred method. However, your most Roll 1 aid stations, or almost all of them, don't have video laryngoscopy. Your guys' medical equipment sets will come with direct laryngoscopy, so it's always good to practice with direct if you can. So typically in the emergency or department or the trauma room, we're not practicing as much with direct than we should. But when you guys are doing your surgery and anesthesia rotations, you guys will practice direct laryngoscopy, which is a good skill to master. And if you have video, even better, but you could presume you're not going to have it in your Roll 1 aid stations or at the battalion level unless you convince your unit to order it. And then we move on to our cricothyroidotomy. So this is a surgical airway. So the endotracheal intubation and cricothyroidotomy are what we call those are going to be the only two definitive airways. The rest are not going to be definitive, like your supraglottic, your NPA, or your OPA are not a definitive airway. So it's important to differentiate what those different terms mean. Most patients for like endotracheal intubation are going to get like a 7 or 8 millimeter tube, depending on whether it's a male or female. And most commonly, we insert it to like 23 centimeters at the teeth. So children is going to be a little bit different. They say the tube size can gauge equal to the little finger. That's also why we like to use the Roslow bags and color tapes and going by size charts so we can have the appropriate tube. And then for our cricothyrotomy, if we have any sort of respiratory distress and they have maxillofacial trauma, or we failed multiple attempts at our endotracheal tube, then we move on to our cricothyrotomy, which is our surgical airway, and that's going to be the tube placed in the trachea through the cricothyroid membrane. All right, moving on to breathing. So typically, almost every trauma patient gets oxygen when they present to the hospital, whether that's a nasal cannula or a non-rebreather mask. It's going to typically depend on patient stability or how the patient looks when they initially arrive on which one we're going to use. But all of them should get a nasal cannula. Some will get a non-rebreather depending on the situation. And then we need to obviously assess their breathing. So our visual inspection, do I see equal rise and fall of the chest? You're looking at the chest wall and the neck. You're looking for any sort of JVD, position of the trachea, and palpation. Is there any crepitus or other obvious injuries? And then auscultating bilateral lung fields. And then some of the common injuries, obviously, we have on there, but like obviously pneumothorax is one of the biggest ones we're looking for or we're worried about in these trauma patients, especially if there's penetrating injury to the thoracic cavity or any blunt injury that we suspect might have caused pneumothorax. And then we also think about like pulmonary contusion, head injuries causing this impaired ventilation, or a spinal cord injury. And then anybody that we suspect, like, hemopneumothoraces, we obviously need to get a chest tube in them immediately. If they're stable enough, or if we don't have the time or the chest tube not set up, we can obviously attempt like a needle decompression or needle thoracostomy in these patients, or we can do a finger thoracostomy as well, where we make an incision like we would with our chest tube, but we're just putting a finger in the thoracic cavity to try to release any sort of blood or tension we have in there. And then we have our flail chest, so that's 2 rib fractures per rib, at least 2 ribs, creating that free segment, and which causes like paradoxical respiration. So it disrupts your normal pulmonary mechanics, and it's gonna, it's gonna cause, first off, significant pain for that patient, but you're gonna see that disruption by obviously in their vital signs as well. They might have hypoxic. They can have an increased VCO2 if you've got that VBG, but this is something to consider. These patients are going to need to go to your ICU for respiratory monitoring. They're going to need significant pain control in these patients, and we'll talk about it more during our thoracic trauma lecture. But these ones are going to need to go to our ICU every time. Typically for pulmonary monitoring, we get something we call a PIC score in these patients, which is what we judge. Based on their score, we kind of judge how their treatment is progressing or whether they need ICU management. So typically that's pain, so we rate it 1 to 3, and then inspiration, like then they take a deep breath, and then how is their cough? We assess their cough, and we look at we do incentive spirometry as well, and we assess that. Typically the goal of 6 to 8 milliliters per kilogram in those patients. Sometimes they'll require significant pain control, like an epidural, and those have been shown to improve survival rate and decrease mechanical ventilation in pneumonia. So we have our closed pneumothorax, which is what one of those trauma patients we had in the scenarios yesterday was a closed pneumothorax from blunt trauma, probably from a steering wheel injury, depending on which scenario you had. But these can be a cold, and they can evolve into a tension pneumothorax. So these ones typically require a chest tube. We'll get into different sizes during our thoracic trauma lecture, which ones require a chest tube versus just monitoring in the hospital with serial chest x-rays and examinations. For a tension pneumothorax, obviously, we have a pneumothorax and then some sort of unstable-ish vital signs, which are indicative like cardiovascular collapse. So, if you have a chest x-ray, great. You don't need a chest x-ray to diagnose tension pneumothorax, though. It's a clinical diagnosis. And these ones require urgent decompression, typically with the chest tube, a large chest tube. If there's any delay, we can do our needle thoracostomy. Typically now we like to do it in the fourth, fifth intercostal space, mid-axillary line. Sorry, dogs bark. All right, and like I said, it's you don't need a chest x-ray to diagnose this, so it's a clinical diagnosis. You can treat it based on your exam, and mechanism of injury, and vital signs. So, and then we have our open pneumothorax, which is a sucking chest wound. As you kind of see in the picture there, you have air leaking into the thoracic cavity, so we typically like to treat something that has a one-way valve so we can let air out without air entering the thoracic cavity during inspiration and expiration. So it's important we identify those penetrating injuries, which is why we need to roll the patient. We need to look at axillas. So you can have a lot that hides in those axillas, which is why you need to lift those arms lift those arms up and evaluate it thoroughly, not just sticking a hand in there and you don't see any blood and you're hoping for the best. You need to actually visualize that you don't have any injuries in those axillary areas. Then you need to roll your patient and assess the entire posterior thorax for any sort of exit wounds or other penetrating wounds when you're looking for an open pneumothorax. All right. You guys are going to read this. All right, what are we thinking for this one? Yeah, so we're going to have decreased tactile fremitus with the affected lung. That's assuming you perform tactile fremitus in PA school, but it is a great physical exam finding. But yeah, you would expect decreased fracture So obviously, it's leading you to normal thorax. Just looking at question taking skills here. They say tall, thin, male patient, right-sided chest pain, shortness of breath. Started while watching TV. It's already kind of guiding you down that path. I think anything that starts with like tall, thin, male, you can probably assume they're looking for some sort of pneumothorax or something like that. All right, let's move on to circulation here. Obviously, moving on to C, so we have our X, ABC, circulation. So this is where we need to optimize oxygen delivery, maximize cardiovascular performance in these patients. This is obviously palpation of all the pulses in our extremities, and we have it on there. So if they got a radial pulse, typically your systolic's higher than 80, femoral 70, carotid 60. So typically we're assessing obviously a carotid pulse, but we also want to check all four extremities, whether they have radial pulses, whether they have DPPT pulses. And if they do, that's usually a good indication that they have at least an 80 systolic blood pressure at that point. But also want to assess their level of consciousness when we look at skin perfusion as well when we're evaluating these patients. So this is going to give us our overall hemodynamic status, whether we need to start any sort of fluids or blood. Typically, we'll start some sort of fluids initially when we establish our IVs in these patients. And this is going to be whether we decide right now whether we need blood or not. So obviously in a trauma patient, we're going to assume that's, hypovolemia from some sort of exsanguination somewhere and they need blood. It's going to be the preferred fluid of choice for these patients. So based on that exam, or this exam on our C, we need to decide what we're going to do and whether we need to get that blood running. Most facilities now have low titer O whole blood, or they will have some sort of emergency release, PRBCs for universal donor. So either of those are usually in every trauma room, even at, like your level 3 trauma centers or your lower level trauma centers. So you need to consider what you have on hand and whether you need to start running that immediately before you get your leg type and cross and everything back before you get blood from the blood bank. That's going to take 20 to 40 minutes depending on the facility or what you have on hand at the time. All right, then we have our different classes of shock here or acute hemorrhage. So this is how, the American College of Surgeons kind of quantify this with this chart of, level class 1, 2, 3, and 4 shock and kind of what their vital signs are going to look like. So a lot of times for class 1, you'll have minimal outward signs. You know, the only thing you might see is tachycardia. Everything else may or may not be normal at this point. So it's sometimes it can be difficult to differentiate this. Obviously, if we have a fully in place and we can monitor urine output, great, but that's typically more on the inpatient side of the house. I think the first thing you're going to see is probably tachycardia in these patients, and then you're going to look at, you're going to evaluate their mental status. So you'll see them getting slightly anxious. They'll be a little bit tachycardic. That's usually like, class 2 when you're looking at these different levels of shock, and then it kind of progresses further down there, typically like tachycardia, over in the 120s or higher. You typically have hypotension with that at this point, so you're looking at like class 3 shocks where the blood pressure is under 90. Their tachycardia into the 120s, and then they may have decreased cap refill. They're tachypnic at this point. And then if you have a blank place, their urine output's usually decreased. But this patient's typically a little bit more anxious, and this is when they might start to get confused. So I know a lot of times when we're looking at these, or when we're doing these scenarios, or when we're looking at it on a slide or anywhere else, it's hard to take the patient's mental status into account. But it is a significant finding we need to consider, especially if that patient presented with normal mentation initially. So this is something that we pay attention to a lot, especially while we're evaluating the patient. So if they went from normal mentation, now they're getting more anxious, maybe they're a little bit confused. It's definitely a sign of shock that we need to address. Then we need to obviously look at their blood pressure, pulse, and everything else involved with that. But it's something that it's hard to kind of talk about on a slide. The mental status is a very important one. Then moving into class 4, that's going to be pretty significant. So they're going to have significant tachycardia. Blood pressure is going to be tanked very low, and then they'll typically be confused and lethargic. And this is definitely a bad sign. And something, and this means they need blood immediately, lots of it. All right, so like I said, typically we get 2 4 IVs on these patients, depending on the level of shock and how bad they are. We may need a central line, but initial fluid resuscitation, especially in trauma, we want blood. Blood products are going to be the best thing for these patients. And like I said, whether you have the low titer or whole blood, the universal donor, it says probably not available on there. I should probably change that. A lot of places have transitioned to low titer whole blood, even in the trauma rooms. I know BAMC did. We did at Darnell. A lot of places have transitioned that. That's because it gives you a more balanced resuscitation. Typically, we used to just start with crystalloids or some sort of, saline lactated ringers in these patients. But now we've realized this can worsen that coagulopathy, and what these patients really need is blood. So we kind of transition to giving blood early in these patients, and the whole blood gives a balanced resuscitation, whereas we used to just use packed red blood cells. And the goal is to do it 1-to-1-to-1, so it's 1 unit PRBC, plasma, platelets. However, those other, the PRBCs aren't going to be frozen. They're going to be refrigerated. The other ones are going to be frozen, so it takes time to thaw those. So what we noticed was that patients weren't getting a balanced resuscitation, especially in the emergency department. We did a study on this a while back, 21 or 22 maybe, at our facility, and basically nobody in the ED got balanced resuscitation, the 1-to-1-to-1. They got PRBCs, but with the time it takes to unthaw everything else, typically they were either in the OR by then, or they'd exsanguinated, or we'd stabilized them, so they weren't getting that balanced resuscitation, which is why we transitioned to whole blood. So it gives us, you have all your clotting factors in there, and they're able to get a more balanced resuscitation. So most facilities have transitioned to that. Some of the studies haven't caught up yet. I know they're doing a large multi-center study right now with all level 1s across the U.S. And I don't think it's concluded yet. I think it concludes in 2025 to put this to bed. A lot of our evidence is based on very small studies or anecdotal evidence for the whole blood, but hopefully we have a definitive answer soon. Anecdotally, we know the whole blood works appropriate, or works better for balanced resuscitation, but it hasn't been proven yet just because of the way we've always done trauma in the United States. Obviously, the military's been ahead of the game with this, and we've used whole blood for a long time now. All right, and here's like our damage control resuscitation guide that, the joint trauma system puts out. Well, I don't want to say every year, but we have CPG guidelines for different trauma algorithms or treatment algorithms that we use in the military, especially in the deployed setting, and that's published by the Joint Trauma System. There's actually an app you can download. I think it's called Deployed Medicine, and it has all of these guidelines in there. So if you don't have the app, it's something that's useful, especially when you're deploying or anywhere you're going downrange. They publish these guidelines of what you're supposed to follow. But I mean, the bottom line on this one is, hopefully you guys talked about it yesterday. Most of you did add calcium to that resuscitation, but that's something we need to consider because we have that citrate in our blood bag. So that citrate combined with the calcium and activators, we need to put calcium. We need to give them usually an amp of calcium when we start with those blood products. That's all this is telling you on here. And then here's our different components within the blood versus our component therapy. So like our 1-to-1-to-1, and as you can see, the whole blood provides a more physiologically normal component therapy when we're giving whole blood. So whole blood is typically better or more preferred. So you have, your coag concentrations higher, platelets are higher, and obviously gives you a higher hematocrit as well. So we like to use whole blood if we can. But if you can do 1-to-1-to-1, great. But typically, like I said, that doesn't happen in the acute setting or the emergency setting. All right, moving on to disability. So we're on D now. So this is our rapid neurologic exam. This is going to be, obviously, we're looking at their level of consciousness. Are they awake, alert, oriented, talking to you? We're looking at the pupillary size, equal, brown, reactive. Are they moving the extremities? Do I see lateralizing signs? Like, are they decerebrate? Are they decorticate? What do they look like when they're presenting? And that's a good indication. Did anybody see, was it last year, what was that quarterback he was like decorticate on the field after getting hit? It looked pretty bad. I can't remember who it was, but yeah, it was definitely, I don't know if you guys saw that, but it was pretty significant. Got hit, he immediately went into that abnormal flexor response after that head injury. But, like I kind of talked about on the break, just may ask questions. So here's our GCS and how we're evaluating it. Obviously if they're alert, oriented, their eyes are open when they come in, they're talking to you and they're moving, great. We got a good GCS or GCS of 15. If not, then we need to look at, or we need to further evaluate, like, do they open their eyes to a painful stimulus? Can they open their eyes when I talk to them verbally? And then are they opening it spontaneously? So, and then, can they talk to me? Is it, are they talking to me, but I don't, like, it's just incomprehensible sound? Are they saying inappropriate things, confused? Or are they oriented? So this is how we're evaluating these motor responses, and then, or their verbal responses. And then for motor, obviously, are they awake? Can they move their extremities? Are they localizing the pain? So if they have some sort of injury, and we're, evaluating them there, are they localizing that pain? Are they withdrawing from it? And then obviously if they have any flexion or extension of pain, more significant responses there, like you see in the pictures. All right, and then looking at our pupil exam, so are they equal, round, reactive to light? Normally pupils should be within a millimeter when compared to each other. Do they constrict with light? It should be, typically most pupils are like 3 millimeters, 2 to 3 millimeters is normal. For dilation, you should see like over 4 to 5 millimeters. And then if you have unilateral dilation, then typically that corresponds to whatever's the ipsilateral injury in the brain. Then you can also see that lateral gaze with the dilated pupils. That's typically like brainstem herniation through the tentorium. So that's pretty late finding and is not good. You also need to think about aneuploidy on these patients too. Shouldn't exceed 1 millimeter, but like it says on here, and we actually never talk about it enough, because looking at the percentages here, it says 35% of the people, healthy people, have aneuploidy. So that should be like 1 in 3 at least, right? In patients. So it is something that you do see quite frequently. However, it may be very minimal and you're not able to tell on exam, but it is, theoretically, you should see it in 1 in every 3 patients, right? I don't think I see it in 1 in every 3 patients, but I do see it. I don't want to say frequently, but I do notice it, not infrequently. All right. So we got 19-year-old MVC, regular respirations. Heart rate's 45. It's not good. Blood pressure 90/60, SpO2 76. What's going to be our initial intervention here? All right, I see some confusion here on some of these answers. So you do not need to get a GCS before you intubate. All right. It goes X, A, B, C, D, E. For a reason, D is after A, so we need to secure their airway first in these patients. So a lot of times we say GCS8 intubate, yes, but airway comes before, obviously, breathing and circulation and disability, so we don't need to assess their GCS prior to any sort of intubation. If they're not able, obviously this patient is not protecting his airway right here. He's got irregular respirations. His heart rate is 45, SpO2 76. This obviously sounds like some sort of intracranial injury based on those vital signs that we're looking at and kind of the discord way they're going. But we need to take this patient's airway first. We don't need to assess a GCS score in this patient, especially if your SpO2 76, you're probably not oxygenating well, so your GCS, that patient's not going to be medicating well in the first place. Usually at a SpO2 of 76. Now, sometimes in certain COPD patients, you may see them still appropriately mentating with that low of SpO2, but typically not. They're going to be obtunded in some way, but especially with that heart rate of 45. And we actually don't give you more in this question, but this patient, we need to take their airway first. That's the priority. Is everybody good with that? Does everybody understand that? All right. So exposing the patient, obviously, we need the patient trauma naked so we can fully assess their entire body for any sorts of injuries. Obviously, places that things like the hide is at posterior thorax, especially in those axillary regions. And then we have to consider whether we can evaluate, especially patient's body habitus, whether we're evaluating, let's say we're rolling them on the left side, like in the picture there. The person on the back side evaluating the posterior thorax might not get a great view of that area that's being rolled. So that's why it's important that whoever's on that left side of the bed there is thoroughly evaluating as well once we roll that patient back down, that we don't have any axillary injuries or injuries on the posterior thorax hiding there. So it's important we do that head-to-toe exam when we're turning the patient, checking all their flanks, checking their back. Sometimes, depending on body habitus size, you got to check, those creases in the buttocks and all the areas that injuries may hide there. So it's important we're opening all those folds if they're that fluffy, or checking all those areas so we don't have, especially if we're having any concern for penetrating trauma, we need to thoroughly evaluate those patients. All right, and then what's our disposition here after our primary survey? So obviously if they're stable, we haven't identified any sort of injuries that require immediate operative repair in the OR, then we can go to the CT scanner. So our dispos, typically for those unstable patients or anybody that needs, operative management, we need to get them to the OR. That's the priority. If they're stable enough, we might send them to the CT scanner if to better identify some of those injury patterns that we see. But we don't want to delay the operating room for the CT scanner. So typically that's going to be made by the trauma team leader or the surgeon, whether they're going straight to the OR versus we're getting any sort of advanced imaging. Now, if they don't need to go to the OR or go for any advanced imaging, then we may need to admit that patient for serial exams and further evaluation and management. And then, can we downgrade them? So, not all patients get admitted or go to the operating room. I can't remember whether it's like, I think it's under 20% actually go straight to the operating room from the emergency department. And it depends on the trauma center and how busy that place is, but that's like kind of typical around that 20% mark. They're going to go straight to the OR. So it's actually a lot of patients aren't, the majority of the patients aren't going straight to the OR. So we need to consider whether we're downgrading them, whether we're holding them in the ED, we're imaging them, and then we're making a disposition on whether they go home versus whether we need to admit them to the hospital for further management or evaluation or serial exams. We also need to make sure we're closing lacerations, we're reducing fractures, we're splinting them, consulting orthopedics a lot of times, and they'll make the decision, yeah, this patient can be splinted and go home. We have an appointment scheduled for them. I would like to say soon, but ortho, nothing's an emergency, but they have their like 7 emergencies and that's it. So sometimes you'll have pretty significant fractures that are going to be seen a couple weeks later. So it's something to consider as well. But a lot of times we'll consult them for our disposition. And a lot of patients actually go home at the end of the day. So. All right, there's our summary. So we covered our, obviously, primary survey, our X, A, B, C, D, E. We've talked about, life, limb, eyesight injuries, triage. We'll move into secondary survey and our tertiary during our next lecture. And what we're going to do for those exams. And what questions do you guys have? I think I saw one here. Let me see about this GCS thing. There's still confusion. We don't need GCS prior to innovation. I mean, if they aren't protecting their airway, they could possibly, they might die before you get to the disability portion of your primary survey. So that's why we need to address the airway immediately, because that's likely going to kill your patient the fastest. Obviously, we start with our X because if they don't have any blood, then obviously they're not going to, there's no fuel in the tank in the system for it to work appropriately. So that's why we need to stop any external hemorrhage. But airway is typically our most preventable cause of death that we can take care of in the acute setting. So we don't have to get to the GCS step under that, or the disability step. So obviously X, A, B, C, D, E, if you find anything within that process first, you need to address that before you move on to the next step in your primary survey. Hopefully that makes sense, but that's why they do it in that sequential order, X, A, B, C, D, E, and you address anything you find throughout that process. You're not supposed to move on to the next step until you've addressed that life-threatening injury and corrected it. Does that make sense, hopefully? All right, what other questions you guys have? Nothing? All right, that's all I got. Hopefully you guys heard me or were able to kind of hear me. I'm sure most of you were like working out or walking your dog or something. And